Our next speaker is Dr. J. Johannigman from University of Cincinnati. He's going to talk to us about bad blood. Thanks.
Thank you. To those who've been in the audience, I'd commend Rick. That was a fantastic lecture, and so many of those points now. I think Rick and I both, in our trauma health systems, we both began to work at level 3 centers. That geriatric lecture is just fantastic. Rick, I need to see you afterwards. Those references in developing those protocols are superb. I would really commend that to you. That's a process I think is incredibly important. I'm going to try to stay on time, and we're going to get to work, talk about something that is very near and dear to my heart, which is the subject of blood transfusion. Because of time, I'm not going to go into the complete history, but just so you understand that some things will always be the same, I want to show you the first recorded history of blood transfusion, Jean-Baptiste Denis. In 1667, back then, a man suffering from fever and delirium, he thought that perhaps by transfusing the blood of a lamb that would lead to tranquility and help suffuse the fevers. Obviously, transfusing lamb blood didn't work so well for him. The patient died, but here's the thing that hasn't changed. The wife sued him for malpractice. And as it turns out, the wife was responsible for poisoning her husband. So not much went on in blood transfusion over the years. I'm going to fast forward to the beginning of the 20th century in the 1900s. So those who are surgeons in the room realize Carrel was the first surgical Nobel Prize winner, and he won it for the technique of vascular anastomosis. Being in Ohio, and this is kind of near and dear to my heart, a fellow by the name of Dr. Cryle actually saw Carrel's work and began to work with vascular anastomosis. And his novel idea was to use that technique to actually do a vascular anastomosis between the donor and the recipient. And here you actually see Cryle in the Cleveland Clinic, actually with just local anesthesia, anastomosing the radial vein to the radial artery of a donor to recipient. And this is how the first blood transfusions, at least in the United States, were actually conducted. And unfortunately, at the time, we didn't know about blood typing. But I just wanted, for historical purposes, this is actually one of the first transfusions witnessed by Mrs. Cryle. And if you ever wanted to read a description of hemorrhagic shock, I've never found a better one, okay? This is bringing somebody out of hemorrhagic shock. This was the donor and the appearance of the donor to Grace Cryle. And I'll give you just a second to read through that, but those of you who've been in the trauma bay and see us resuscitate somebody and catching them before they expire, that's a wonderful description of resuscitation. Now, hold on though, continue to read on, observe what Mrs. Cryle sees in the donor. Meanwhile, the donor, a large man of ruddy complexion, seemed to shrink to half his size. He was white, hollow-eyed, and sighing. Perspiration stood on his brow. Constantly, he asked for water. What were they doing to the poor donor? They were putting him into shock. Yeah, so they were resuscitating one, put the other in shock. Fortunately, they stopped the transfusion about that point, and they both went on because they were actually brothers, and it worked very well. They went on to lead a life of some 60 years after that in a full life, but those were some of the first transfusions done. And then really about this same time, two pivotal things happened, which is we understood that there were blood types, and then we also began to develop methodology to actually store blood, and that's with citrate solutions. So now we could actually hold blood ex vivo and then reinfuse it. Historically, the First World War was the first time that whole blood was transfused to any degree in any volume, and it was actually the British who were doing it, and Walter Cannon, who was an American surgeon, actually worked with the British, saw this and brought it to the American battlefield in a limited version, and World War I ended, and primarily and principally we forgot about blood transfusion between World War I and even World War II. So we entered World War II. Interestingly enough, as surgeons, as physicians, we actually thought that the tenet at the time was hemorrhagic shock could be largely treated with crystalloid and albumin-containing solutions. And so we went to war, especially in North Africa, and at D-Day we were actually using colloids rather than blood. And freeze-dried plasma. And I will return to the discussion of freeze-dried plasma, but you heard in yesterday's lecture on pre-hospital resuscitation, freeze-dried plasma is coming back. It's actually not a new concept. The first time we used freeze-dried plasma was at Pearl Harbor. The problem with freeze-dried plasma is seen here, and those bottles have been around since Normandy and Pointe du Hoc and in Guadalcanal. The problem was in World War II, to make freeze-dried plasma, we would pool about 100 donors' plasma in a big vat and then distill it down to make units of freeze-dried plasma. The problem with that is we didn't records for the recipient, and so there was about a 35% incidence of hepatitis transmission, and it was recognized in World War II that if you gave the soldiers freeze-dried plasma, a lot of them got hepatitis, and hepatitis was about 30% lethal during that era, so we kind of gave up on freeze-dried plasma, but we'll come back to it. This person is very important as both a surgeon and as a military surgeon. Edward Churchill was the chief of surgery at Mass General and went over as the chief surgeon for the African Command for the United States Army, and he was convinced by looking at the British, who again were transfusing whole blood over in North Africa, that whole blood was the solution. If you think that for a second I'm going to tell you something new, or yesterday's lecture or today's lecture, that I have novel thoughts, I'll disabuse you of that, because I have this book and it still sits on my desk. These are Churchill's memoirs from the Second World War, and I can assure you that every time I think I thought of something new, all I have to do is open that book, and he had it all down. We knew this back in the Second World War about blood, about plasma, the way we resuscitate. He describes the triangle of death, which we'll talk about. A brilliant surgeon. So, in World War II, a little bit of blood, some plasma, still colloids. Then go back to my own hometown. This is my mother or father in the 50s. If they had been injured, that's the city of Cincinnati Fire Department in the 50s. Between World War II and Korea, in the Korea era, if you needed blood, you would have come to a hospital like here in Phoenix or in Cincinnati, and you would have gone to the blood bank and you would have used this. Back in the late 50s, early 60s, whole blood was utilized as a means of transfusion. You could take blood from a donor, you would store it in a bottle, a citrate solution, and you could keep it in the refrigerator for up to 3 weeks, and that's what we used. Now the problem became kind of the military's problem. We go to Korea, and then we subsequently go to Vietnam, and we, the United States military, are trying to ship bottles of whole blood and get it to Korea or Vietnam with a 3-week shelf life. And by the time we get it to Korea or Vietnam, it's 16, 17, 18 days, and we could only keep it in theater for less than a week. So we, the military, went to the blood banking community and said, how do we solve this problem? And I'm going to briefly describe to you a number of well-intentioned scientific initiatives that I think were actually misinterpretations that led us down a pathway that we are just beginning to unravel and recover from, but led us to really some great mistakes, I think, in transfusion practices. So the blood bankers back in the 60s, when we asked them, how do you store blood better, did something that seemed logical at the time, which is to take a unit of whole blood, divide it into its relative separate components, and then store each of those components at an idealized temperature so it could last longer. So the theory was a good one, that you could take whole blood, you could split it into packed cells, cryo, and plasma, and then at any point in the future, after it had been stored in a refrigerator for some period of time, you could put those three things back together, and it would be absolutely equivalent as though you were using whole blood. The problem is that is unequivocally, unreversibly wrong. No one ever tested that theorem that you could break blood apart, reassemble it, and it still looks like whole blood. And in fact, it does not. It looks something entirely different from whole blood, and I will show you why that is the case. Realize that when you give a unit of whole blood, the moment they begin to break it down, they irreversibly and irrevocably change that around, excuse me, and make it for the worse. So the first thing you do when you donate whole blood is you dilute it. You dilute it down by a factor of 1/3 with CPD solution. So you dilute the blood out. Oops, let me go back here one. Yeah, you dilute it out so that whole blood, instead of being concentrated, is diluted down to 30% hematocrit. You see, you half the platelet count, you drop the fibrinogen and total volume goes up to 700 cc's. So even fresh blood after it's donated, as soon as you dilute it down, it's no longer the same. So component therapy, I think, was well-intentioned, but a big mistake. We never tested the theorem, and I'll show you data that when you start to store blood, you do things to blood that irreversibly change it for the worse. Now, at the same time, there were a number of papers that were put out in the literature by some huge icons in surgery that were misinterpreted. Shires and some others were looking at what was the appropriate fluid to use until the patient got to the hospital or until you could get them bottles of banked whole blood. And Shires and others came to the conclusion that you could use crystalloid to temporize the patient, But the thing that everybody forgot is, in Shire's papers and all these other papers, they said you can temporize with crystalloid until whole blood is available. What was happening is we were no longer using whole blood. We started using components, and we'd give crystalloid up front, and rather than resuscitating with whole blood in the back, excuse me, we were getting to component therapy, and so this was an entirely different resuscitation strategy. So, clear please? We got onto this thing I call the crystalloid detour, and again, we just misread the papers, and so this is what led us to ATLS. And those of us in the room old enough to be taught ATLS in the first or second generations, we got to this ATLS resuscitation algorithm that said, when a patient comes in, you give them 2 liters of crystalloid. If they respond, so be it. If they don't, you give them more crystalloid, and then you start giving them individual units of component cells, and after 10 units of components, then you start giving platelets, then you start giving plasma. Well, I taught this, Rick, you probably taught this for years. And I will tell you, I will show you the data that if you continue to insist on using this algorithm, you will kill 2/3 of your patients. This is a lethal algorithm, and the problem is there is not a single piece, a single shred of scientific evidence that is brought forward that actually shows this works. And I will show you significant evidence that says this doesn't work. This is the way to kill a patient. So you heard yesterday, and I hope all of you are very conversant with the Lethal Triad. When I walk down to the trauma bay, this is what I think about. Is my patient in the Lethal Triad? How do I keep them from getting further into it? And if you think about that crystalloid resuscitation, that's a perfect way to put somebody there because you're using acidemic solutions that are cold and make patients coagulopathic. Crystalloids irreversibly make somebody coagulopathic. So yesterday you saw this paper quoted. I've quoted this paper every time I've given this lecture. For the residents or the early providers in this room, if there's one paper you want to keep in your files, this is Borgman's paper. This is the military data that first demonstrated to us that the relative ratios of transfusion changes mortality. And again, you saw this slide yesterday, but essentially it says that if you use ATLS resuscitation, okay, you'll kill 2/3 of your patients undergoing a massive transfusion. When you begin to go to a balanced resuscitation algorithm of 1-to-1, the mortality goes down dramatically and statistically significantly so. And again, you see what's interesting about it, you never even get them off the table. Those who went on to die from a 1-to-1 algorithm, yes, some of them bled to death, but others died from CNS or airway issues. What does that mean? You have to have at least gotten off the table and gotten to the ICU and not bled to death from coagulopathy. So it's not a perfect algorithm yet, but I'll show you the data that supports this change. So interestingly then, this is circa 2006, 2007. John Holcomb and others, we really thought the data was too good to be true. We started challenging ourselves in the civilian community. People like Brian Cotton and others started in the civilian world looking at their own data retrospectively, and sure enough, papers like this were published that said, yeah, if you look at our own civilian data, this business about transfusion ratio does appear to be valid, and this is a graph that almost perfectly mirrors the military data from a civilian retrospective review, and you can see the same changes in mortality as you go to a more balanced resuscitation. Well, now as people begin to look at, is it just plasma and packed cells that make a difference? We began to look at platelets. And the data also convincingly is starting to say that the earlier you put platelets into the algorithm, and remember, we used to teach in ATLS that you don't even need platelets until after 10 to 15 units of transfusion. But now the data actually says, when you look at it, that the sooner a patient gets a pack of platelets, if they're massively bleeding, the more likely they are to get off the table. So now, 2006, 2008, the data's saying that if you really want to resuscitate a patient, you give them plasma, packed cells, and platelets. What does that sound like? It sounds like you give them whole blood. We're not inventing something new. We're going back to what we did originally, which is just to give somebody whole blood. And here's whole blood. This is my favorite picture. This is an ICU nurse in one of our 10 hospitals in Balad, and he was AB positive, and the patient we were struggling to get out of coagulopathy was AB positive, so the nurse walked over to the laboratory, stuck out his arm, gave a unit of his AB blood. We were in the operating room at the time. It is really cool. You get this unit of blood that's still warm, you give it to the patient, and they stop bleeding. It's like a miracle. The first time I saw it, I turned to anesthesia and said, "What the hell did you just do?" in a good way, because the patient was getting better. So, and then what's cool is John put a bandage on his arm, grabbed 2 cans of Diet Coke, ran back around, and was in the ICU when the patient with his AB positive blood is going back, so he took care of the kid. It's an amazing, amazing drug. And so, yes, we in the military still use it. And I would actually commend, I think the next step in Ohio is in the rural areas is to get the community to develop the capability of doing a walking blood bank for their own community. I've seen Marines do it and turn whole blood over in less than 30 minutes. I know we can do it. The technology's not that difficult. Here we are at 2 o'clock in the morning doing a whole blood drive. You get whole warm blood in 45 minutes. If you're bleeding blood, you need back whole blood. I think we need to work through some regulatory hurdles, but the military database, we've transfused over 6,000 units of whole blood with a complication rate of well less than 1%. Whole blood is where we should be at. And the data says if you're massively transfused and you get a single unit of whole blood, you're going to have a greater chance of surviving than if you don't get whole blood. Now, a lot of this data then starts coming out. It gets challenged. There's a lot of literature about survivor bias. I'm going to skip over this pretty quickly, only to say that there is some legitimate concerns about the initial data because some of the patients who died and bled to death before even getting 10 units weren't counted. And there is some problems with that, but that's been looked at pretty substantially, and it probably does not negate the validity of the entire data. But because of this, there were 2 key studies that were done, and again were mentioned yesterday. The first is PROMMTT, the second is PROPER. I'm going to show you those subsequently. PROMMTT was a prospective data collection, and PROPER was a randomized controlled trial. So there were 10 trauma centers that prospectively collected all the data whenever a trauma patient got transfused, and the finding out of the PROMMTT trial was that the sooner we got to a balanced resuscitation ratio, the more likely the patient was going to do well. So one of the things that PROMMTT showed us, and it's illustrated in this picture, is that if you played catch-up, that is, if you started with a lot of packed red cells and then an hour or 2 hours into it, then caught up with plasma, those patients did not do as well as if you started with 1-to-1 from the very get-go. Okay, so PROMMTT validated 1-to-1 and said use 1-to-1. So what did that change for us? That changed for us in Cincinnati. We now put liquid plasma down in the trauma bay, and when we have a patient sick enough to get a unit of cells, we always hang a unit of plasma side by side. We start 1-to-1 and stay 1-to-1. Okay, so what else did we get from? The other thing I took away from PROMMTT are these things called trigger points. We use these in the trauma bay. These are reliable indicators that the patient's going to have a massive transfusion, and they are ones you've heard about yesterday, you've heard about today, and you'll hear more about, namely the presence of coagulopathy, hypotension. Why anemia? Well, one, it could be that indicating that the patient's substantially bleeding, but the other thing I think is if you see a patient that's anemic already in the trauma bay, they've already gotten too much crystalloid. And crystalloid is an acidemic solution. It creates coagulopathy. I think it's actually a marker of over-crystalloid resuscitation early on. Base deficit, acidemia, okay? And heart rate tachycardia and positive fast. So that's the second thing PROMMTT drew out for us. And here are the findings of the PROMMTT study. I commend to you if you want to, there's innumerable. Right now I think that there's at least 20 reference papers that came out of the after-analysis action of PROMMTT leading to this. So then what comes next? This was kind of the kicker. This was finally the Cadillac. This was the prospective randomized trial of blood component therapy, 1-to-1, 1-to-2, and 1-to-3. Now what's really interesting is, back when PROMMTT was started, we knew PROPER would follow on, and we proposed to the FDA that there be 3 different arms in this trial, 1-to-1, 1-to-2, and 1-to-3. Well, what was fascinating, this was proposed to the FDA, and the FDA said you cannot use 1-to-3. They actually ruled that out. They said 1-to-3 is lethal, 1-to-3 is dangerous for the patients. And in 2008, when this was first approved, how many hospitals in the United States were still using a 1-to-3 resuscitation algorithm? How many hospitals today still use 1-to-3? The FDA 6 years ago said you can't use that, that's too dangerous. So the trial went forward, and it finished in 2013, and it was just published earlier this year. And again, as they talked about yesterday, it validated, is it 1-to-1 or is it 1-to-2? Well, they were not statistically significantly different. Those of us involved in the trial still wonder what would have happened. And I will tell you pragmatically that unless you try to get to 1-to-1, you won't be somewhere in that sweet spot. By trying to get to 1-to-1, most of our transfusion ratios end up about 1 to 1.5 anyway. So is it 1-to-1 or 1-to-2? I don't know. but it should not be less than 1 to 2. And there you can see the p-values just miss statistical significance. There's a numerical and a difference favoring a 1-to-1 ratio, and they seem to be reach the endpoint of coagulation earlier, but it wasn't statistically significantly different. So again, in Cincinnati, these things are so important that in the trauma bay, we use point-of-care testing. We have a point-of-care INR drawn on all trauma stat patients. We look at a venous blood gas, and we get a temperature, and we call timeout at 10 minutes after the patient arrives, and we try to review these trigger points. I will tell you that if there are more than 3 trigger points positive, I get really nervous, and I try to get the patient somewhere out of the trauma bay, either to the OR or to the ICU in under 30 minutes. That's a PI point for us. 3 trigger points positive, out of the trauma resuscitation bay in under 30 minutes. I learned these over in Balad, and in fact what we used to do, you could see would hang the trigger points from the light rail here, and so you could just walk up and down the light rail and see who had the worst trigger points. This translates readily for us back home in Cincinnati, Ohio. You heard a little bit about tranexamic acid yesterday, and I would echo that I believe in it as well, but I'll show you why I believe in tranexamic. Realize that in Europe, tranexamic acid has been available over the counter, like Tylenol, for the last 30 years. It's not a prescription drug. There was this huge trial called the CRASH trial, and how many of you have read trials that have 10,000 patients in both arms? There was a lot of controversy about this, but the CRASH trial suggested that tranexamic acid was a survival benefit, and people were back and forth debating, but the one that convinced me was this paper because I was witness to it in theater. This is actually called the Matters paper, and this was written by the Brits, because in Afghanistan, the Brits were down in the southern area where the Marines were really taking a lot of serious casualties. And our hospital was up north. We were seeing the Marines go through Bastion, receive wonderful care from the Brits, and then be flown to us within 24 hours. And when we'd read these operative reports, we'd see time and time again, balanced transfusion, and we kept on reading, a gram of tranexamic acid, a gram of tranexamic acid. We didn't know what it was. So we asked them about tranexamic acid. Johnny Morrison, one of the British surgeons, came over to the United States Army Institute of Research and wrote a paper with us looking at it, and it showed a survival advantage for seriously wounded cohort-matched soldiers if they got tranexamic acid early in their experience. And there's the survival benefit, and I believe in it because I saw it come time and time again. So how do we use it? Actually, we, the military, believe in it so much that the Secretary of Defense for Health Affairs has written this off as an approved protocol. Medics in the field tonight, Special Forces medics, carry it on their kit pack. They will give a gram in the field. We give a gram in the field in Cincinnati, Ohio. We give a gram in the emergency room, and whether we've given tranexamic acid or not is on our checkpoint, our checklist before we operate in the trauma room. It's checkpoint number 4. We ask, has tranexamic already been given? If not, should we be giving it now? Real quickly about PCCs, and Rick, for the older folks, we do use prothrombin complex concentrates. But this is the other place we use liquid plasma. We have liquid plasma not just down at our level 1 trauma center, but we keep it at our level 3 trauma center. The most common reason we use it at our level 3 trauma center is just the patient you described, the little old lady who comes in on Coumadin. If you answer, yes, I've had a fall, yes, I'm on an anticoagulant, you get pulled out of the triage track, you get a point-of-care INR, and you're sent to the CT scanner. If that POC INR comes back greater than 1.5 and you have blood on your CT scan, you have liquid plasma going in within the first 30 minutes. We start to transfuse liquid plasma right away, then we can call for either freeze-dried, or if they have CHF, we can go to PCCs, but we're trying to target very, very early intervention. We don't waste liquid plasma. We track it with our blood bankers, and if the liquid plasma is getting at the end of its expiration, which, oh, by the way, you can keep liquid plasma for 3 weeks, then the blood bank simply comes down, pulls it out, and gives it to the next patient upstairs who needs plasma. Real quickly, because I don't want to go over my time, the other thing that's changed, I don't know how to resuscitate somebody without TEG. I don't use INR other than to alert me that this is a sick patient. It's a trigger point for me, but it's not an end point. We use TEG and TEG exclusively now. I will tell you that please disabuse yourself that this is too complicated or complex. Get used to using it. You can pattern recognize. It is really very simple. The first part of the TEG, called the R time, tells you if you need plasma. The second part here, called the alpha and the K, tell you if you need fibrinogen. And the height of this curve right here, called the MA, tells you if you need platelets. I can look over my shoulder with the resonance and say plasma, cryo, or platelets. And this comes back within 20 minutes. We draw TEGs on all the trauma stats stats, and especially if they're going to the OR, the TEG graph is already up in the OR over our shoulder so we in anesthesia can look at it and modify our resuscitation strategy. Real quickly, and we can clear please, just to show you where we're trying to go with the basic science, my partners took a look at this whole blood stuff and they said to themselves, we've never actually in the lab resuscitated human beings, or resuscitated a lab model the way we do human beings. That is to say, in the 100-year history of shock resuscitation, we either shock an animal and give them back their own blood or give them crystalloid. Nobody's ever shocked an animal and gone to the animal blood bank and taken animal blood bank stored blood and given it back to the animal. So my partners, in a stroke of what I think is brilliance, they went and made a mouse blood bank. They took an isogenic strain of mice, banked the blood, stored it so they would create these storage lesions, and then they resuscitate mice with old blood, and they look at the inflammatory. Turns out that mouse blood ages about twice as quickly as human blood, but now what we can do is we can look at the cytokine elaboration of what happens when you resuscitate animals with either fresh whole blood, a 1-to-1 ratio, or lactated ringers, and that's bad. MIP-1 alpha is an inflammatory cytokine. You don't want that, and you can see the difference when you resuscitate with crystalloid versus whole blood versus balanced resuscitation. Not only that, but we can look at pulmonary vascular permeability, and you look at the mouse. If you want to get ARDS, give them crystalloid. If you want to keep their lungs healthy, give them 1-to-1, give them fresh whole blood. So then with respect to old blood, I will leave you with this following message. Many of you have read that transfusion of blood is associated with increased mortality. It is not transfusion of blood. It is transfusion of old blood that makes the patient sick. And here's the demonstration of exactly that. We've never looked at all the bad things that happen to blood when you put it in a refrigerator, and it's not just the red cell, it's the solute. It's microparticles, it's microaggregates, and that's what's making old blood bad. If you don't know the age of your blood that you're giving your trauma patients, shame on you. We do now, and the military tracks it on a daily basis. We took it from 34 days over in theater. Now the military is alerted if our blood is more than 15 days old in theater, and we do something to fix it. We in Cincinnati have gone back. I'll bet you that your blood in your center is probably about 3 to 4 weeks old. 3 weeks old is the trigger point that makes patients statistically significantly more likely to get in trouble. So we're working on that. For sake of time, I'm going to just commend you to work by Makeley and Pritz on whole blood and microparticles. It's there in the literature. So in light of time, I want to be I want to first of all thank Pete and the ASTRAC group and all the committee, but leave you with how am I different. So we're much more likely, as I told you, in the trauma bay, we'll hang blood, packed cells, and plasma together. We'll send off the TEG. We'll be checking an INR right away. I'm absolutely dependent on point of care. My blood banker sits on my trauma performance improvement committee, and quarterly they tell me how many units of blood I've wasted. And I hear if we waste blood, because it is a precious resource and they are our greatest ally, and we don't want to waste that precious resource. We have incorporated tranexamic acid. As you heard, there's going to be a large pre-hospital national trial. We send a TEG all the time. TEGs are not that expensive. Get used to it. Learn how to use it. Teach your team how to use it. I believe it's absolutely important. We do try to do this time out. What am I waiting for? Yes, I would commend, if any of you know which United States pharmaceutical company is going to get FDA approval to bring freeze-dried plasma to the market, would you please text me at j.johannigman@uc.edu, because I will invest my 401k in that product. Freeze-dried plasma, when it hits the market, will change how we do things. So we still have a lot to learn, and I think it's important that we understand where we've gone wrong so we can correct those things in the past. Resuscitation is much better now than it was in the past, but we still have much to learn, and we need to rethink and constantly challenge ourselves at venues such as this to make sure that we're hitting the right targets and on time. So we have a lot of work left to do, and I thank you very much.